Hi guys, this is part 1 video for chapter 24, the forearm, the wrist, and the hand. And your book covers the entire thing, but I've decided to divide it into over 2 weeks. And this week, primarily, we focus on the forearm and the wrist. So this video will talk about the anatomy of forearm and the wrist, but since a lot of the musculatures are related to your hand, so we're gonna go over that as well. Okay, so this video, the contents include the bony skeleton first. We talk about the ulnar radius and the hands, and some ligamentous structure that are mostly at the wrist. And muscles, we're going to focus on the extrinsic here, and intrinsic muscle within your hands, we're going to introduce it to you next week. And lastly, the last part of the video, we'll be talking about the nerve of forearm. Okay, so let's review the bony structure of the forearm and the hand. We already reviewed the proximal end of ulna and a radius. If you haven't watched the anatomy video of the elbow, please do so before you proceed here. So I would like to focus on the distal end of ulna and a radius, but before we do that, I want to introduce this connective tissue structure that connects to long bones here. Okay, so this is the interosseous membrane that are connecting ulna and a radius. And much like what we saw in a lower extremity with the tibia and a fibula, they're kind of bound together. But the only exception here is that tibia and a fibula doesn't overlap each other. But since for upper extremity, we are able to do supination and pronation, and particularly when you do pronation, these two bones are gonna kind of create an X-shape format that it'll cross over. Okay, but anyway, structurally it's very similar. Okay, so moving on to the distal end of radius and ulna, notice how radius now became much wider. So here's the radius, right? Because it's on the thumb side, on the lateral side, and then here's the ulna. In the elbow, ulna had this big hook, the olecranon in the back, and then it was much bigger compared to the radial head, but that relationship is reverse here. The radius becomes big and wide, and then the ulna is much smaller. And then notice that the distance, or the ulna doesn't come far down as much as the radius. So radius, in fact, will provide a primary stability of your wrist joint, because ulna there's a huge gap between the end of the ulna and then these little carpal bones. Okay. One important structure that I want to mention here is the styloid process. Okay. So on each end, even with the radial, and then the ulna end, this little nub here, these are called the styloid processes. Okay, so they're both styloid process, and then either on a radius or ulna. Okay, and the other thing is the articulation between here. I mean, this is the distal radial ulnar joint. There's a little notch on the ulna. It's called the ulnar notch, where the head of not the head of radius, but the head of the ulna is this part right here, and then in here there's a little notch for the radius to sit in. Okay. So that's about it for the distal end, and I'm gonna move on to talk about the carpal bones. Okay, right here. So we have a total of 8 carpal bones, and then it's usually divided by proximal row and then the distal row. Okay, so the proximal row is these 4 bones. Okay, so let's go over each one of them. So the first one right here is the scaphoid. Okay, so the scaphoid is located on the lateral side of proximal row. Okay, and then right next to it is the lunate. Okay, so lunate, if you can take a look at the left corner right here, it has looks like a little half moon shape. So because of that reason, it's called a lunate bone. Okay, and then right next to lunate is actually what we call the triquetrum. Okay, notice that if I move around, triquetrum is actually this only the bottom part of the carpal bone. And then these are actually two separate bones. And then what's sitting on top of it is called the pisiform. Okay. And if you actually trying to find the styloid process first, and then, on the owner side, move your finger up distally, actually towards your pinky, then you feel this little bony protrusion, and that is your not piriformis, pisiform. Okay. And if you put your hands on the floor or on a hard surface, that particular bone will hit against the floor. Okay. Okay, moving on to the distal row. So the most laterally we have trapezium. Trapezium is the bony structure that articulate with the metacarpal, first metacarpal. Okay. And then right next to that we have trapezoid. And this trapezium and a trapezoid, the name is kind of confusing. You just have to memorize them. And what we have is capitate. And then lastly, hamate. Okay, so hamate, the shape is very unique. And if I rotate, it has a little handle or knob that are sticking upward. Okay. So that particular area is called the hook of hamate. Okay. This area. Okay. So if once you find the pisiform this one right here, yeah, pisiform, and then move your finger not straight up but slightly laterally, about 45 degree, you should be able to feel a hook of hamate. Okay. So those are the 8 carpal bones that are located in your hands. And once again, please make a note that the wrist articulation is between the radius and scaphoid, and then also the lunate. Okay, so these 3 makes up your wrist. It's not the entire proximal row of carpals, because here we have a huge, this area is an open space. But because we have this, we have a much greater motion when we do ulnar deviation, which is, if you are in the anatomical position, bring your pinky towards your body. Okay. So that movement is much bigger compared to the opposite way. Bring your, pointing your toes, pointing your fingers away from your body. Okay. So because of that space right here. Okay. And then this become clinically important because injury could happen to this particular region. But I just leave it at that right now. Okay, so that is your carpal bones. And then moving on distally. So we have, much like in our feet, we have metacarpal. Okay, so first, second, and third, fourth, fifth. And then, again, it's kind of like your foot. We have phalanx, right? And then the proximal and middle, and then distal. For second through fifth fingers, we have 3. But for your thumb, you only have proximal and distal. Okay, so the joint name is similar to the foot as well. From distally, here we have DIP joint, and then we have PIP joint. Okay, and then this is carpal, not carpal, metacarpal phalange joint. So MCP joint, and then here this is the carpal metacarpal joint. Okay. All right. So that's about the structure that I want to introduce. And is there anything else? Oh, this little guy right here, we also have a sesamoid bones, much like what we saw at the bottom of our feet, and that are located on the first metacarpal. Okay, so let's go over some ligaments. And The hands are much like feet, you know, since it's being created by tiny bones. um lots of ligament has to be present, like in between each bony structure. And then obviously I don't expect you to know all of it, but here I'm gonna go over the major ones so that it's more relevant to injury that we're gonna talk about. Well, for your wrist, first of all, I want to mention these two collateral ligament. Okay, so much like what we saw in the elbow, we have two collateral ligament, and the first one is the radial collateral ligament. Okay, that are located on the lateral side. If I rotate the structure, it's not that strong structure, and you could actually sprain this particular ligament. Okay, and on the other side, we have ulnar collateral ligament of the wrist joint. Okay, so when you say ulnar collateral ligament, then it's confusing because you don't know if you're talking about the elbow or the wrist. So oftentimes a lot of people say MCL, the medial collateral ligament. Okay, but still, yeah, you have to clarify because there's a lot of medial collateral ligament as well. Okay, so that is two collateral ligament that I want to make sure that you know. And as you see in here, there are a lot of ligaments and you might be freaking out, but it's okay. There's only a handful structure that I expect you to know. And one of them is this guy right here, the piezohamate ligament, okay? So as we mentioned earlier, the pisiform is protruding anteriorly. So if I try to rotate here, you notice that piezohamate ligament will create this nice tunnel between the pisiform and then a hook of hamate. Okay, so these two protrusions that are on the medial aspect of your palm has this ligament over it and then create a tunnel. Okay, so we're gonna talk about later what is running through it, but if I briefly say it, that it's ulnar nerve and artery. Okay, here maybe I can show that to you. Just like that. Okay, well, in fact, it's actually underneath the ligament, but this is the ulnar nerve. Okay, and that becomes significant because if you have an injury to this particular area, then you are most likely to be, you know, injuring ulnar nerve, the distal end of the ulnar nerve as well. Okay, so moving on, I'm gonna add one more layer. That didn't do much. There we go. So the other structure that I want to mention here is the flexor retinaculum. Okay, and hand, we're gonna see a lot of tendon that are originate from the forearm and then coming into the hands to create motion of your fingers, right? And much like the feet, the bulk of the musculatures are located on a forearm. And if you look at it, you know, inside of the hands, there are only a handful of intrinsic muscle that will do a fine movement. But the bigger motion or strong motion is controlled by the extrinsic musculature. Extrinsic muscles, again, it's the, you know, the definition of it is originate from somewhere outside. In this case, it's a forearm, and then originate into the hand. Okay, intrinsic, on the other hand, it originate and inserts within the hands. Okay, so because of that, numerous tendon that are running from the forearm coming into the hands, we need some sort of structure that holds the tendon down, because otherwise, you know, mechanically it's not advantageous to have all these tendon that are running from far away and then it's just loose. Okay, so we need something that holds the tendon down, and then this flexor retinaculum particularly creates another tunnel, a bigger tunnel actually, on the palmar aspect of the hand. Okay, and this is important because particularly this, you know, tunnel is called a carpal tunnel, which is famous, right? I'm sure you've heard of carpal tunnel syndrome if you are using a computer or, like, you know, on the keyboard typing and putting a lot of pressure in this particular region. You're gonna compress this structure that's inside of the carpal tunnel. Okay, which we're gonna talk about it in the next section. Okay. Okay, so that is carpal tunnel, or the flexor retinaculum. And let's see, I want to add one more layer. There we go. Okay, so the other structure that I want to mention is the fibrous sheet. So as I mentioned, same thing here. There's a long tendon. This particular tendon is the one of the flexor digitorum tendon. Okay, so you have flexor digitorum profundus and then flexor digitorum superficialis. I'll introduce it to you in a muscle section. But these tendon has to, in order for them to flexes the finger, it has to be, tightly attached to the phalanges, right? And these tissue, okay, or these X1 is the cruciform part of the fibrous sheet, and then the circular one is the annular part of the fibrous sheet. But anyway, these fibrous sheet holds the tendon down so that it's closely attached to the phalanges. Okay, and trigger finger is another injury that is relevant here, but just remember there is a structure that surrounds the tendon for now. All right. Okay, lastly, we have palmar carpal ligament, and it's similar to flexor retinaculum that are located a little deeper, but the palmar carpal ligaments holds every tendon that are running underneath. Okay, so it's not just a single or it's not just a certain structure that is holding down, as we saw in a flexor retinaculum, but palmar ligament or palmar carpal ligament holds everything that's running underneath down. Okay, so we have something similar on the other side, actually, if I could flip it nicely. There we go. Okay, so this is the extensor retinaculum. Okay, so extensor retinaculum holds all the tendon that are running on the back side of your hands. Okay, so don't get confused with the name, because the extensor side only has one, and then on the palmar side we have that and then the retinaculum. Okay, so it's multi-level actually. And lastly, most superficially, of course, is the palmar aponeurosis. Okay, remember we talked about with the Tommy John surgery, we have the palmaris longus muscle that are inserting into the palmar aponeurosis. Okay, so this is what I was talking about. So it's a very thick connective tissue, much like what we saw in the plantar fascia, that expands on the palmar aspect of your hands. Okay, so that's it for ligaments, and now let's move on to the muscles. Okay, so let's review the musculatures on your forearm, and then first let's review on the palmar or the anterior aspect, and then we're going to move on to the posterior aspect. Anterior aspect, there are 3 layers. So the first layer has 4 musculature. Okay, so the first one is the pronator teres. We saw this muscle already in the elbow section, so if you haven't watched that video, please review that in there. Okay, so right after these pronator teres, or before actually, these 4 muscles that I mentioned, it all originate from the medial epicondyle. Okay, so if I rotate right here, you can appreciate how these 4 muscles that are originate from the same common origin. Okay, so moving on after the pronator teres, what we have is flexor carpi radialis. Okay, and my advice to you, if you want to memorize these muscles, is because the name indicates the location and then where it goes to. Okay, so particularly with the flexor carpi radialis, because it's it it goes to the thumb, which is most lateral structure. So it has to come first. So like the flexor carpi instead of ulnaris, which we're going to see later, the radialis come first. Okay, so and then carpi means carpals, right? Obviously, and then it goes to the radial side. Specifically, it goes to the base of second and the third metacarpal. Okay. What does it do? It flexes your wrist. Okay, and then also assist with the radial deviation. The next muscle here is palmaris longus. Okay, and as I mentioned before, 20% of the population is missing. Okay, so to know if you have it, we checked it already, so I'm sure you already know if you have palmaris longus or not. Okay, inserts to the palmar aponeurosis, and then the only function this guy has is the flexion of the wrist. Okay, moving on. The last of the four is the flexor carpi ulnaris. Okay, so once again, it's on the ulnar side, so it makes sense, right? And this one, it inserts to pisiform, hook of hamate, and then the base of fifth metacarpal. Okay, so kind of has a multiple insertion. Let's isolate and take a look at it. It doesn't really show on this structure, but it'll insert not just the hamate, but also on a pisiform. Okay, the hook of hamate part is not showing here, or the base of the fifth. Okay. All right, so those are the four superficial musculature, and you can memorize it by placing your hands on a medial, actually placing your thumb on a medial epicondyle, and then if you lay your fingers on the anterior aspect of the forearm, then you can, try to memorize the index finger is a pronator teres, and the middle finger is, flexor carpi radialis and such. Okay. Okay, so let's go deeper. Okay, so that was the superficial layer, and the intermediate layer, we only have one muscle. Okay, so which is flexor digitorum superficialis. Okay, when you say digitorum, flexor digitorum, what does it mean? It flexes your fingers, right? And this is the same with the foot, and same here, but except we have two separate digitorum. One is superficialis, the other one is profundus, which we haven't seen yet. Okay, so the superficialis, as the name indicates, it's more superficial compared to profundus. And the insertion point is different. Okay, so I'm going to zoom in here. Okay, superficialis inserts to the middle phalange. And as they do, they split to two different tendon and it inserts to the middle phalange. Okay, so do they have a function at the distal end? Are they able to flexes at the DIP joint? No. Okay, because it only goes to here. They can do PIP joint flexion, but they cannot do DIP flexion. Then who does the DIP flexion? This guy right here is the flexor digitorum profundus that we're going to see in a third layer. Okay, but anyway, so this muscle is actually pretty strong though, flexor digitorum superficialis. It has a very broad origin. Okay, it originates from medial epicondyle of the humerus, and then also has a little bit of ulnar and the radius origin as well. Okay, so that was the flexor digitorum superficialis, and let's get rid of that. And to move on the deepest layer, so here we have flexor digitorum profundus, and the flexor digitorum profundus originate from the medial aspect of coronoid process of ulna, and it comes down and splits into four and inserts to each finger at distal phalange this time. Okay, so this particular muscle is, allow us to be able to bend our finger at the very tip of it at the DIP joint. And of course, it'll do a flexion at PIP joint. and also the metacarpal phalange joint as well here. Okay. So that is the deepest layer, one of the muscles in the deepest layers. And what's right next to it is the flexor pollicis longus muscle. Okay. So pollicis is thumb. Okay. So this particular muscle originate from the radius and then inserts to the distal phalange of the thumb. Okay. And if, of course, as the name indicates, it flexes the thumb. And we already saw, did we see this before? Can't remember if I showed this to you, but I think I did. But anyway, the last muscle that I want to talk about on the anterior aspect is the pronator quadratus. Okay, much like the pronator teres, this particular muscle will create a pronation movement. It connects the radius and the ulna at the distal end. Okay, so moving on to the extensor side or the posterior side. And to orient ourselves, here's the triceps brachii and then anconeus muscle that we saw earlier. And most of these superficial extensor muscles are originating from the lateral epicondyle. So I'm gonna rotate this model just a bit so that you can see all of the musculature. The first muscle is actually not originating from the lateral epicondyle is the brachioradialis. And in the elbow chapter, we saw this muscle. It assists with the elbow flexion, and particularly most active when the thumb is pointing up, right? So right underneath that, here we have the extensor carpi radialis longus. Okay, make sure you remember the whole entire name. And this particular muscle originates from the supracondylar ridge, meaning that not the epicondyle, the lateral epicondyle, but slightly above that. Okay, and notice that there's the flexor side. We have flexor carpi radialis, and that's it, right? But it's actually extensor carpi radialis longus, meaning that there's the brevis, the shorter version of it. So here we have the longus. It inserts to the dorsal aspect of the base of second metacarpal. Okay. And slightly inferior to that, we have the extensor carpi radialis brevis. Okay, so they're right next to each other, and they basically have exact the same function, but insertion point is a little bit different. The longus inserts to the base of second, and then the brevis inserts to base of third. Okay, let's see if I can show you that. Just like that, you see. Okay, so both of these muscles extend at the wrist, and then also does the radial deviation. Okay, so moving on to the next muscle is the extensor digitorum. That's it. No superficialis, profundus, or longus. It's just the extensor digitorum. It originates from the lateral epicondyle and then comes down, inserts to second through fifth digits. Okay. And what does it do? It extends the fingers. Okay, so last muscle in the superficial layer is the extensor carpi ulnaris. Okay, no longus brevis because there's only one. This particular muscle inserts to the medial aspect of the base of the fifth. Okay. And then when this muscle contracts, it'll produce a movement of wrist extension and then also ulnar deviation. All right, so that was the superficial muscle. Okay. Next, I want to introduce you to outcropping muscles. Okay, so the outcropping muscles are the ones that goes to your thumb, and then it produce a movement at the thumb, but it originate from the posterior aspect of your forearm. Okay, and then kind of wraps around and comes down to the thumb. And the first one here is the abductor pollicis longus, abductor pollicis longus, and that one is the most, it located most I would say laterally, okay? And then right next to that, we have the extensor pollicis brevis that are running kind of along with the abductor pollicis, okay, longus. And then it inserts to the proximal phalange of your thumb. And one more right here that are kind of not running parallel to the last two muscles that we just saw is the extensor pollicis longus. Okay, so this one inserts to the distal phalange of the thumb, and then it extends the thumb. Okay, so these three muscle, okay, extensor pollicis longus, brevis, and abductor pollicis longus. This muscle comes down and it inserts to the thumb, and then what's important here is that it creates what we call the anatomical snuff box. Okay, so this triangle area right here. Okay, so this is the anatomical snuff box. Okay, I want you to try on yourself to extend your thumb or like bring your thumb up. Much like, you know, when you're trying to shake somebody's hand, and then bring your thumb all the way up, and then you notice there's a little dimple on the bottom of the thumb. That's your anatomical snuff box, okay? And what's important is this is the, important landmark to find a scaphoid carpal bones. Okay, sometimes in the fracture of the scapula, people will complain of a point tenderness right in the anatomical snuff box, okay? And not just that, we also have the radial artery that are running inside of here, okay? So you could actually try to take a pulse if you wish, and then find the radial artery in here, okay? Okay, so that is the anatomical snuff box. And going back to muscles, okay? Whoa. I want to strip down some more muscle to get to the deeper layer here. Okay. So here we have a supinator muscle. I wonder if I could go one more down. There we go. Okay, so that is located in the deepest layer. Okay. And we saw this already in the elbow section. So we also have extensor indicis muscle. Remember, we have extensor digitorum, which goes to the index finger as well. But extensor indicis is specifically just going to the index finger and extends the index finger. And we also have one for pinky finger, the extensor digiti minimi muscle. Okay, so this is also the deeper layer that you need to know. Okay, I think this concludes the muscular portion of this lecture. Okay, so the last section of the video, let's talk about the neurological, the nerve of the forearm and the hands. Okay, so in the brachial plexus video, we saw the terminal branches of the arm or the brachial plexus, including a median nerve, and then the radial nerve we saw in the elbow that are coming down on the anterior aspect, and then ulnar nerve that are running behind the medial epicondyle and comes down and innervates all the muscles. Okay, so median nerve, let's start with the median nerve we see here running on a medial aspect of the cubital fossa, and then it comes down, innervates all these forearm flexors, what we saw in the superficial layers, and then intermediate layer and a deep layer. There are some exceptions though. So the first exception would be the flexor carpi ulnaris. This is innervated by ulnar nerve, okay, which we see right here. There we go. Ulnar nerve. And then also the flexor digitorum profundus, which only half of it, on the medial half of it, is innervated by ulnar nerve. With that minor exception, the median nerve actually innervates most of the musculature on the anterior aspect. Okay, the radial nerve on the other side. Okay, this nerve innervates majority of the posterior aspect of, the muscle that we just saw. Um, the ulnar nerve, what does it do? Does it only innervate the flexor carpi ulnaris and the flexor digitorum profundus, half of it? No, it comes down, and then as on a medial aspect here, this is the ulnar nerve, and ulnar nerve provides innervation to majority of the intrinsic muscle of the hand, which we haven't really talked about it, but I'm saving that for next week. Okay, so it kind of has a separate roles, right? In general, median nerve does the forearm flexors, radial nerve does the forearm extensors, and the ulnar nerve does the hands. Okay, but I want to mention the course of how these nerves run, particularly in the median nerve. Okay, so here's the zoom in version of your wrist. And here's what we saw, the palmar carpal ligament earlier. And what's underneath is all of the tendon that are originate from the forearm coming into the hands, right? And if I rotate just a bit, okay. And here we saw flexor retinaculum, okay. So whatever the structure that are running above, it's fine. Like, I mean, it's not going to get compressed because look at the space we have between the flexor retinaculum and then palmar carpal ligament, okay. So I want to go deeper. So if I remove some of the structure, okay, there we go. Okay, so here we have a better look of flexor retinaculum, okay. So what is underneath the flexor retinaculum? So we have, what is this tendon right here? Okay, so this is the flexor digitorum superficialis. Remember that intermediate layer muscle? And then it inserts to the middle phalange. Okay, that's running underneath the flexor digitorum, flexor retinaculum, also known as the space as the carpal tunnel. Okay, and then you notice there's another tendon that are running. Those are profundus. Okay, so how many tendons do we have? Even though they're originating from this common sheath, right? But we have 2 on each finger, so that means not counting the thumb, right? Obviously. So we have 8 tendons that are running, okay, in the carpal tunnel. And we have one more actually. The last one is the flexor pollicis longus, remember, in a deep layer. So that makes the 9 tendons that are inside of the flexor retinaculum. Got it? Okay, so another structure is the median nerve. Okay, and you might wonder what is this nerve that are running on top? This is also part of the median nerve, but median nerve split into the superficial layer, the palmar branch, and then the deeper layer. Okay, so this deeper layer is in danger of being compressed because of such a small space in a tunnel, carpal tunnel, and then 9 other tendons are running with it. Okay, and flexor retinaculum is very, very tight, and it doesn't have any property of stretching out. So it's very thick, inflexible structure. So if you have some sort of inflammation going on underneath, then it'll definitely compress the median nerve. Okay, so that is called the carpal tunnel syndrome. Okay, so that is the carpal tunnel. Okay, the radial nerve comes down and then innervates all the cutaneous structure on the back of the hand, but does not do any innervation on the hand intrinsic muscle. And the ulnar nerve innervation to specific intrinsic musculatures will be go over in next week. Okay, so this concludes the first part of the video, and the second part, as always, we're gonna go over some injuries.